So you've been on Instagram, you've been looking around, you see this innovative, awesome breast augmentation technique, brand new, nobody's talking about it, but it's all over social media. It's called Preservé. What is it? Is it hype or is it science? So today, I've got the pleasure of being joined by Dr. Jessica Walker, again, making her third or fourth appearance on the show. And we're going to unpack Preservé, kind of the ins and outs, what it is, what it isn't. Is it as new as the internet makes it seem, or is this just something old that's being applied in a new way? So welcome to the Trillium Show. My name is Dr. Jason Hall, board certified plastic surgeon, Knoxville, Tennessee. Author of the book, The Art of Aging, back there. Pick up a copy on Amazon. Today we want to talk about Preservé breast augmentation, the minimally invasive Awake breast augmentation technique that is all over the internet. So for that, I'm going to turn to Dr. Walker, who is a Motiva implant user. Yep. Motiva is this new company out of Costa Rica who has come up with a new breast implant that has also taken the internet by storm recently, and discuss what Preservé augmentation is, how it's used, and kind of the ins and outs of it. So, Dr. Walker, welcome back.
Thank you for having me again.
Of course.
I guess I must have done well the first time to be invited back. So.
Well, the first time, the second time, the third time.
Yeah.
So, yeah. So tell us a little bit about what Preservé is.
Sure. So Preservé is it's a newer technique for breast augmentation, but it's not really new. We'll talk about that, but it is a system where you can theoretically make a smaller incision, and you go in and dissect with a balloon that blows up the pocket, almost like a tissue expander, which we use a lot in reconstructive surgery, and then you place the implant through that smaller incision. And it is being, it's kind of more for if you don't want general anesthesia. That's how it's supposed to be a faster recovery. It can be done under local anesthesia with potentially some oral sedation as opposed to having to get an IV and going fully to sleep. But, I've kind of thought about it. I've broken down the procedure, having previously done general surgery. It's very similar to some stuff we used to do. And Awake breast augmentations are not new. It's not in my generation, but I know previously I've had attendings in training say they used to do them in the office. So I don't think that's really a newer technique, but I kind of break it down and we can talk about all the different aspects of the procedure and what my thoughts are on it. So, and your thoughts.
So the first thing I hear on that one is smaller incisions. And I think, the incisions I've been making for breast augmentations for the last, nearly 20 years are pretty little. How little are we talking?
So the recommendation is 2 to 3 centimeters for them. And realistically, when we're doing a breast augmentation with the advent of the Keller funnel, which is essentially a sterile icing piping bag to help squeeze implants through smaller pockets, we have already shrunk down our incisions. So realistically, most of my breast augmentation incisions, I try to keep them around 4 centimeters anyway. So 3 centimeters to 4 centimeters to me is not a drastic change. So yes, by definition, it's a smaller incision, but it's also a smaller implant. So with Preservé, it is size limited. So they really recommend it for implants that are, I believe, like around 300 cc's or less. So kind of more of that athletic, what the internet's calling like the ballerina or the Pilates boob, that smaller athletic breast. So you can't even use it for bigger implants, which a lot of my patients that I have here, it's very classic. My patients come in, they want to be proportionate to their body, around a C to a D cup, or kind of what they looked like when they were breastfeeding or when they were pregnant. And that's not that breast implant. That's too small for that. So to me, yes, it's a smaller incision, but it's also a smaller implant. And not a lot of my patients need that small of an implant.
Yeah, I think that's one of the things that I've noticed reading about it and just like you guys watching on the internet about it, is that it really isn't a technique that is for that C cup, D cup, which a lot of people in our practice are looking for.
I would say that's the majority of my practice.
The implant goes over the muscle. Is that right?
Correct.
Okay.
Yes.
Do you do a lot of over the muscle implants without Preservé?
I do. I would say still the bulk of my practice is still in the submuscular, and I talk about this on my social media, everything is patient dependent. So when you come in for your consultation, we kind of talk about what your goals are, what your size goal is, your anatomy, and what your lifestyle is. And we kind of cater that operation to those things. So Preservé is made for the subfascial or above the muscle space. And I do those every day without the system. So do I think it's necessary to get in that subfascial space? No, I don't. But yeah, I know I do subfascial. I would say I'm probably 1/3 subfascial, 2/3 submuscular right now. I don't, and I think I kind of am like you on this. I like to tell patients I'm not a one-trick pony. There's surgeons who do everything subfascial. There's surgeons who do everything submuscular. I think it really depends on the patient.
Mm-hmm. I think that is a good transition into the why, because patients who are watching this show, who are out on the internet researching breast augmentations, hear a lot of over the muscle, under the muscle. Mm-hmm. What makes somebody a good candidate for an over the muscle implant?
So over the muscle for me in general is someone who's very athletic. So they do, bodybuilding, CrossFitting, a lot of heavy chest work. They don't want to be limited in that. Or somebody who has a very physically demanding job, also doing a lot of heavy chest lifting, things like that at work. Because when you're going under the muscle, it's a muscle and muscles contract. And eventually, if you do a lot of heavy chest work and you really have that developed pec muscle, it's going to cause what under the muscle causes, which is, a wider cleavage gap, animation, things like that. So for me, over the muscle is kind of that athletic person who really doesn't want to limit their chest workouts.
One of the things that I know patients are concerned about, that surgeons talk about a lot with over the muscle implants, is what happens to that implant over time. Mm-hmm. Specifically, that implant has a tendency to go south towards your abdomen over time. What about the Preservé or any other subfascial technique prevents that from happening?
So I think the biggest thing, if you're concerned about that, the implant moving south, is reinforcing that area. So using a mesh support is one thing to help kind of reinforce that inferior pole, is what we say, or the lower aspect of the breast, to help support the weight of the implant. Whether the implant is big or small, this can happen to any size implant, but, studies do show over 400, that's kind of my sweet spot, is where implants are a little bit heavier, more rates of malpositioning, things like that. But in the subfascial space, I am more inclined to use a mesh, knowing that there's a lot more lower pole stretch and the implants do head south.
That's one of the things that I've noticed just in watching you using these Motiva implants, is that a lot of those implants that you're putting over the muscle or having a mesh support used. Mm-hmm. And I've done a lot of subfascial, over the muscle implants over time. And I typically, before Motiva came out, and total disclaimer, I don't use the Motiva implants, but before Motiva, and since Motiva, I typically will use a textured implant on top of the muscle to prevent that. The texturing on that implant is designed for, and this is for the patients, this already, the texturing on those implants is designed so that the implant sticks to the scar capsule that's created around the implant, to keep that implant from moving around, to keep it where we put it, to resist that, resist gravity effectively. And the texturing works pretty well.
Yes.
Motiva's implants, they don't like you to call them textured. They're textured, but they're textured very, very lightly.
Yes.
And because they haven't been around a long time, we don't really know whether that texturing is significant enough to prevent that implant from moving and stretching. Would you agree with that?
Agreed, yes.
I guess the next thing to really talk about is how surgery trends happen. You know, if you've been on the internet recently, you know, the deep plane facelift has had a huge increase in popularity because of social media. Motiva designed a social media campaign when they rolled out their implants in the US, which drove a lot of demand for those implants. And I think it's interesting to watch how these trends spread in the social media era, because they all follow a fairly similar pattern. Deep plane is a little bit different because it's a technique that's been around since the 90s.
Yep.
And so it has a fairly long track record. But what typically happens is that something, you know, a surgeon pioneers a new technique, a company, Establishment Labs and Motiva, come up with a new technique. It takes off on the internet. People start offering weekend expert courses in how to do it. There's a big push at our meetings teaching people and talking about it. And then a lot of these trends typically die off, and, you know, 2 years later, nobody's talking about them. Do you think Preservé is going to follow that trend, or do you think this is something that's got staying power?
I think, you know, and like you said, it's social media that kind of makes these things really kind of inflates their buzz around the world. But I honestly, I don't think it's going to have enough traction. I mean, it's there. If it works for surgeons, it works. If they like the technique, but I don't think it's an absolute necessary, and I don't think it's something that will be added to our practice or my practice. So I think it'll stay around, but I think it'll lose its hype.
Yeah, I kind of agree. I think we've seen a pop because of social media. I think it's gonna die off as more people try it. Because like anything,
Right.
you know, and I think a deep plane facelift is a good example of this. It's still surgery. It still depends on the person who is doing the operation. And invariably with any new procedure, you're going to see a huge number of early complications
Right.
from people trying and learning. And I think that Preservé is probably going to go that same route.
Well, it's like anything that we do in surgery or in healthcare in general. You know, you can't just stay static. You have to change things and do things to advance. You want to make this technique better. You want to make this technique better. And that's what we're doing. We're trying these new techniques to see if it's really giving an advancement to our practice or not. And some things do, you know, do that and change our practices. And we do make definitive changes. But then there's a lot of stuff that we try. And 5 years later, you're like, you know what? I don't love it. It's not giving me the best results. And there was a time where we were using a lot of saline implants, and, you know, everything kind of ebbs and waves. It's the same thing with above and below the muscle. There'll be like a 5-year period where all the meetings say go below the muscle, and then the next 5-year period, all the meetings say go above the muscle. So it's just, I think in medicine and in healthcare in general, we always have to be learning and changing just so we can improve ourselves. But there's just always going to be some stuff where it's like, it didn't really add much to my practice. So, you know, and I don't like the technique, or I can do it better this way. So everything's always comes in ebbs and waves in healthcare.
Yeah, and I think from a surgical standpoint, especially, you know, now having the benefit of years and years of patient follow-up, you see what works for you. You also see what works for the patients. And, you know, we've talked a little bit about complications on the show before, but one of the things that determines whether a technique has staying power is the problems that we end up dealing with after the fact.
Right.
Do you know much about what potential problems can come from the Preservé?
I mean, I personally don't know, but just, you know, making an educated surgical guess just on how the technique is done. Obviously, the implant itself, every implant is going to have its own complications down the road, unfortunately. Implants are not a one and done surgery. I wish they were, but they're not. So there's always revisions that need to be done. The technique itself is a little bit less controlled, in my opinion, as opposed to actually looking in the pocket and seeing the dissection. It's the same thing when we used to do, I mean, I never did these, but transaxillary or through the armpit, you don't have as good of a pocket, or going through the areola, the periareolar incision, I don't think you have as good a visualization. So I think the visualization can play into it. So maybe the pocket dissection isn't the best, or higher rates of bleeding, because again, some of these surgeries, you're not even using the bovie, which is electrocautery, how we take care of bleeding in the operating room. So I personally, again, haven't done it, but just knowing how the technique is described, I'm like, these are the sets of things that could happen that I can take care of better, in my opinion, just doing a regular standard breast augmentation.
The point that you just made about the dissection is important, because one of the foundational principles of any surgery, whether it's breast augmentation or facelifts or abdominoplasties or liver resections or gallbladder surgery, is seeing what you're doing, is controlling the surgical field, controlling bleeding, and with a blind technique like this, you have no control. You're relying on, instead of fine control with a cautery to identify places that can bleed and stop them before they start bleeding, which is the kind of a foundation of breast augmentation surgery, you're relying on a balloon to essentially blow up the space for the implant without you seeing anything, and then just sticking an implant in.
Well, and aside from just bleeding, I mean, it's pocket control.
Yeah.
You got to be able to see. You don't want to dissect too far to the side of the chest. You don't want to go too far medial. You can get symastia. And when you can't see, I don't know how. I mean, I know it's done by feel. A lot of it's done by feel, and you're direct fitting the same size or to the same size implant. So theoretically, there shouldn't be over dissection. But if it's misplaced or you have the balloon dissector in the wrong place, you can make the pocket too big or in the wrong place, which is its own host of problems with implants if you don't have good pocket control.
Going back to the incision, I think this is where the incision comes into it. Through a small incision, we have instruments that are designed to be able to see everything and be able to dissect that pocket very precisely. You can use an incision that's half a centimeter. Half a centimeter is like this.
Right.
You can make an incision half a centimeter or a centimeter bigger. You can see everything and be very precise with what you're doing,
Right.
as opposed to, relying on a balloon
Right.
to do the work for you.
Right. Which is not new technology.
No,
Right?
we did
used to
hernias
do
like
that
that.
in hernias, laparoscopic hernias. That's the first thing I thought of when I was learning about this technique. I was like, oh, I did this in general surgery when we used to do laparoscopic hernias. You use a balloon to blow up the space. It's the same, and the same thing with like expanders. You're blowing up a space. So it's not new technology, really.
Yeah, and I think the difference with the hernia surgery, if you remember back to general surgery, hernia surgery, you're dissecting in a space that doesn't have a lot of blood vessels.
Right.
You're in a spot that's kind of a natural dissection plane. In the breast, you're not.
No.
You're creating a space that isn't a natural bloodless plane. So the potential for bleeding seems to be a lot higher. And I think that, and one of the things, capsular contracture is something that we always talk about with patients when we're talking about breast augmentation surgery. One of the, I think, biggest contributors to capsular contracture is bleeding.
It is.
Because bleeding means inflammation. Inflammation means scarring. Scarring is what a capsular contracture is.
Yes.
And so this is where I think the lack of any long-term data on Preservé today, which is April of 2026.
Yeah.
No, May of 2026. So that's what happens when you have two teenagers. You lose track of time. But the lack of any long-term data as of right now, we just don't know what's going to happen.
Right. And this is what we do in anything we do in healthcare. You don't just jump in and use something new. You stop and think about, okay, so I did used to do this. I did used to use a balloon dissector in hernias. And how does it work? What happens? And that's what we're doing. And this technique may work great for some surgeons, but to me, it's just, I haven't justified it yet to bring it into my practice because of these things. We're just talking it out and, okay, well, if I'm blind dissecting, I don't have as much pocket control. There's more risk of bleeding, which means more cap con. Like, you got to think about these things before you bring anything into your office.
Yeah. I think a good analogy would be if this were a new drug and that gets rolled out to the market, COVID shots, without any testing, with very little data on what happens long term, I think most people would go, nah, I'm going to wait and see what happens here before I just start popping this new pill.
Right.
with surgical techniques, there doesn't seem to be that hesitation.
No, well, and I think this is the age, again, of social media. And sounds a little counterintuitive, but I always tell my patients to stay off social media unless they're watching me. Because, you know, you got to be hesitant about what you see on social media, what you believe on social media, the hype of social media, because everything's heavily edited. Especially before and after pictures, you got to be worried about, now we got to worry about a lot more about AI generation of things. I've had patients bring AI photos in as their goal photos. And I'm like, that's like, I can't achieve that. I'm not a computer. So the age of social media, I think, makes everything looks all fancy, shiny, new. So everybody wants to, use the new stuff because their favorite influencer uses it or because this person says to use it. And you really got to do your own research on stuff. So I'm always cautious with anybody on social media.
Yeah. And I think the other thing that kind of opens the door to something that we really have to be careful with in surgery, especially when you have device companies that are pushing their new proprietary technique, you got to follow the money. Because a lot of the people who are on the cutting edge of, especially with Preservé, they're quoted in the magazines, they're all over social media. You do a little digging, they're all paid by the company as a consultant, as an advisor,
Right.
as a scientific
Speaking at the
liaison.
meetings
They're all taking money. The people who are writing the research papers for Motiva implants, for Allergan implants, for Mentor implants, with their initial studies, are all paid advisors.
Right.
So, of course, they're going to tell everybody how great they are.
Right.
Because they're taking money from the companies. Whether they're, now, do I think it's malicious? Probably not.
No.
But just like with the drug companies, if the people who are testing the drugs are paid by the company that makes them, their bias is automatically going to be
Yes.
toward the people who are writing the checks. I mean, it's biblical. His bread I eat, his song I sing.
Yes.
And so you really this is where I think it's going to take time and independent research. People like you and me, who are independent from the device companies, using the device, publishing results to see what the actual long-term data is.
Right.
I guess for patients out there who are interested, what are some questions that they should be asking if this is something that they think they might be interested in?
You mean specifically for Preservé?
For Preservé or for
breast
any breast
augmentation.
augmentation in general.
I mean, I always recommend that you should always see a board certified plastic surgeon, obviously. You want to look at befores and afters and not just on social media, on websites, like in the office, things like that. And then the one thing, you want to mesh with your surgeon. You don't want to go in and have them, it be a quick consult. Our consults take an hour, sometimes more. But I've seen surgeons who do 5-minute consults, and most of the time is actually spent with either the nurse or the nurse practitioner, and I'm the one doing the surgery, so it should be me talking to you. So you want to have a good relationship with your surgeon. I recommend a board-certified plastic surgeon, and then you want to look at befores and afters, and you want to make sure that you guys are on the same page, that you're understanding what can be achieved and what cannot be achieved, because I think a lot of times patients, we see a lot of body dysmorphia in plastic surgery, and patients are unrealistic in their goals. And then just what their complication rates are. Are they taking a lot of people back to surgery? And I think the biggest thing that we always talk about, the best form of flattery, yes, befores and afters, but is word of mouth. If you have a lot of patients who've had a really good experience with you, that's going to help. And so if you're looking for a surgeon, talk to your friends, talk to your family. A lot more people have probably had plastic surgery than you think. If they're forthcoming about talking about it, and they'll tell you who was a good experience, and if it wasn't a good experience, and who they'd recommend, and things like that. So be cautious on social media. And then with the Preservé technique, we've had people call our office asking if I do this technique, and at this time currently no. And reasons why I'm not ready to bring it in is, again, I don't like the lack of pocket control. I like to see my pocket. The patient's being awake versus going to sleep, it is a perk for the patient, but to me it's a perk when they're asleep because, again, they're not moving on the table. There's not a risk of them moving on the table, so I can see better, dissect better, more safe for the procedure. And then you're also limited in size, the implant that we can choose for you. You can't go too big, and that's not my patient population. And then one big thing for patients is cost. It adds when you have all these new procedures, new devices. It adds to the cost of for me, a breast augmentation. It's kind of all the surgeries we do, it's a lower cost procedure. And if you're going to add to the cost, I can't do that to my patients. If in something that I truly don't believe in.
Mm-hmm. Yeah, I think that all of those are good points. I think one of the things for any procedure that you need to ask as a patient is what can go wrong? How often do you personally, who I'm interviewing to do my operation, how often do you see those complications in your practice? Because the published complication rates and an individual surgeon's complication rates may be very different. And then how do you deal with those? What happens if, how are those problems addressed? Mm-hmm. And because, this is plastic surgery's retail medicine.
It is.
Your insurance isn't paying for the procedure. They're not paying for complications.
Mm-hmm.
If you have a hernia surgery and you have to go back to the operating room, your insurance company covers that cost.
Right.
If you have a breast augmentation, you have a problem, they don't.
Right.
And so, how those things are dealt with. And I don't want, as we're kind of coming to a close, I don't want to scare people away from a new technique. I think the purpose of this is more to give people an understanding of what this new technique is, mm-hmm. to know the limitations as we see them right now, and to empower people to ask the questions that they need to ask to know whether this is A, the right technique, but then if B, the downsides are worth it.
Right. And that's all they see on what you're going to see on social media or the marketing. It's always all going to be positives. You never hear about the negatives unless it's somebody's personal experience. And that's just something that you have to be prepared to ask questions about is if something does happen, what happens? So when you're looking for these techniques, newer techniques, you're always going to see the positives, but you got to remember you have to look at the negatives as well. Mm-hmm. So
I think that's a great point. If you have questions about breast augmentation, you have questions about Preservé, whether or not it's something that would be right for you, feel free to shoot us an email, info@trilliumsurgery.com. You can look either one of us up on social media, Instagram. You can look up Dr. Walker's TikTok. All of that stuff is going to be in the show notes. So until then, we'll see you on the next show.